Welcome to Pharma Zone. I'm Dr. Sirisha, and today's topic of discussion is adrenaline. You can see a funny depiction of Jerry running away, which is a flight response, which needs adrenaline in our body to show this. Our nervous system is divided into peripheral nervous system and central nervous system. Our peripheral nervous system is further divided into autonomic nervous system and somatic nervous system. The autonomic nervous system comprises of sympathetic system and parasympathetic system. The drugs which modulate sympathetic system can either be agonists, which we term as sympathomimetics, or antagonists, which we term as sympatholytics. Today's topic of discussion, which is adrenaline, is a non selective alpha and beta agonist. Before going into what is alpha, before going into adrenaline proper, let us first learn about alpha and beta. So, what is catecholamines? Catecholamines are the molecules which have catechol nucleus and amine moiety attached to it. The endogenous catecholamines include noradrenaline, adrenaline, and dopamine. The synthetic catecholamines include isoprenaline and dobutamine. Phenylalanine is the necessary molecule required for the synthesis of adrenaline. Phenylalanine, in liver, in the presence of the enzyme hydroxylase, gets converted into tyrosine. Tyrosine, under the influence of the enzyme hydroxylase, that is tyrosine hydroxylase, gets converted into dopa and dopamine. This tyrosine hydroxylase is the rate limiting enzyme in the synthesis of dopamine, noradrenaline, as well as adrenaline. The dopamine is usually formed in neuronal cytoplasm, and dopamine enters into the neuronal vesicles under the influence of beta hydroxylase, forms noradrenaline. Noradrenaline is formed inside the vesicles of neuron. In the presence of high steroid levels, further methylation of noradrenaline happens, and this happens only in the adrenal medullary neurons, resulting in the formation of adrenaline. Whenever a proper stimulus is given, the tyrosine gets converted into dopamine. Dopamine enters into the neuronal vesicles through VMAT, vesicular monoamine transferase 2, transporter 2, into the vesicle, and then in the vesicle gets converted into noradrenaline and is stored there. When appropriate stimulus is present, noradrenaline, which is present in the vesicle, gets exocytosis done. This exocytosis is calcium independent. And obviously, for every rule, there will be an exception. Some noradrenaline does diffuses into the neuronal cytoplasm. This noradrenaline, whatever is being diffused into the neuronal cytoplasm, is metabolized by the enzyme monoamine oxidase. The fate of noradrenaline, whatever is being released into the synaptic cleft, is three. Either it must act on the postsynaptic alpha and beta receptors, or it should get metabolized by catechol O methyltransferase, or it should be taken back into the presynaptic neuron either through norepinephrine transporter and VMAT, vesicular monoamine transporter 2. The metabolism of norepinephrine, usually through COMT, results in vanillyl mandelic acid, which is a biomarker for noradrenaline. What are the adrenergic receptors? They are broadly divided into alpha and beta. Alpha is further divided into alpha 1, alpha 2, whereas beta is divided into beta 1, beta 2, beta 3. This is somewhat too much of generalization, but if at all you have to remember, MBBS graduate can remember, undergraduate can remember as alpha 1 is stimulatory in nature usually, beta 1 is stimulatory in nature usually, beta 2 can be either stimulatory or inhibitory based on the location. Alpha receptor. Adrenaline has the highest potency on alpha receptors on comparison with noradrenaline and isoprenaline, whereas isoprenaline has the highest potency for beta receptors. These alpha receptors and beta receptors are G protein coupled receptors. Alpha receptors are either GQ or GI or GO. GQ type of GPCRs usually has secondary messenger system as inositol triphosphate diazyl glycerol or reduction of CAMP which is for cyclic AMP or opening of potassium channels which is for GO type of GPCRs. Whereas for beta receptors it is GS type of GPCRs which mainly cause either increase in the cyclic AMP and increase in the calcium channel opening. Let us have a small glimpse of which receptor is present at what location and causes what response. Usually, alpha 1 is present in the vascular smooth muscle and is responsible for contraction. Alpha 2 receptors are present on pancreatic beta cells and is responsible for reduced insulin release. Beta 1 is present in heart and is responsible for increased force of contraction, increased heart rate, increased conduction velocity. Beta 2 is present on smooth muscle. At the level of blood vessel, it causes vasodilatation. At the level of bronchi, it causes bronchial relaxation. Beta 3 receptors are present on the adipose tissue and they cause lipolysis. Before going into any further, let us once have a concept of alpha and beta clear. Alpha receptors are further divided into alpha 1 and alpha 2. Alpha 1 receptors are primarily postsynaptic and they are responsible for whatever action we see, like vasoconstriction. Whereas alpha 2 receptors are presynaptic. They give negative feedback and inhibit further release of noradrenaline. Beta receptors are divided into beta 1, beta 2, beta 3. Beta 1, we have one heart and two lungs. That's how we remember. Beta 1 is present in heart, beta 2 is present in smooth muscles of bronchi and blood vessels. At the level of heart and also at the level of juxtaglomerular cells of the kidney, we have beta 1 receptors. This juxtaglomerular cells of the kidney, whatever beta receptors are present, beta 1, they are responsible for renin release and further increase of blood pressure. Adrenaline acts as potent agonist at beta 1 and beta 2. Beta 3, which is primarily present in the adipose tissue, the agonist is mirabegron, and noradrenaline acts as a potent agonist for beta 3. Let us have a knowledge of adrenaline's pharmacological actions now. Whenever a lion is running behind us, obviously we'll have tunnel vision. We have lot of steroids released from our body. In the same way, we'll have better hearing abilities. We'll have tachypnea. We'll have tachycardia. The muscles will be high tensed. In the same way, we'll have increased blood glucose levels either because of liver's ability of converting glycogen to glucose or because of alpha 2 mediated reduced insulin release. In the same way, at the level of adrenal glands, we produce lot of steroids and we show tremors and shaking. Now, let us apply the same knowledge more scientifically. In the heart, because of its action of on beta 1 receptors, adrenaline increases heart rate primarily by acting on sinoatrial node. In the same way, it increases force of contraction and also conduction velocity is increased. Why force of conduction, cardiac contraction is increased? So that more blood is pumped to your muscles so that we can act fast. In the same way, when conduction velocity is increased, this is responsible for arrhythmogenic potential of your adrenaline. Applying the knowledge of adrenaline and its receptors on blood vessels, alpha receptors causes vasoconstriction, whereas beta receptors causes dilatation. So alpha causes constriction, beta causes dilatation. When we apply the same knowledge to the blood pressure, adrenaline, because of its action on alpha and beta, causes first initial rise in BP followed by a small fall in BP. This adrenaline acts on alpha 1, alpha 2, beta 1, beta 2 receptors. But obviously, Adrenaline, though in very low potency, though in very low concentrations, can act on beta 2 receptors. Your noradrenaline has no effect on beta 2, whereas isoprenaline has no effect on alpha only. Applying this knowledge, let us have a small graph where we are using small doses of adrenaline which causes fall in BP due to beta 2 action. In the same way, when therapeutic doses of adrenaline is given, alpha 1 mediated vasoconstriction is seen, followed by a small beta 2 mediated vasodilatation and fall in BP. Applying the same knowledge to norepinephrine, where the action is limited to alpha 1, alpha 2, and beta 1 receptors. Beta 1 present in the heart is responsible for increased heart rate, force of contraction. Alpha 1, because of its vasoconstriction, causes increased in blood pressure. Because of continuous and sustained increase in blood pressure, there will be reflex bradycardia for norepinephrine. Coming to adrenaline, it acts on both alpha 1, alpha 2, beta 1, beta 2. Beta 1 mediated increase in blood pressure, alpha 1 mediated increase in the blood pressure is seen, and beta 1 mediated increase in the heart rate is also seen. Isoprenaline, which has no action on alpha, there will be unopposed beta action. Unopposed tachycardia, because of which fall in BP is seen, as well as beta 2 mediated vasodilatation and fall in BP is seen. Coming to the action on eye, adrenaline causes mydriasis, that is dilatation of pupil. This dilatation of pupil is mediated through alpha 1 action, and adrenaline effect is called as active mydriasis. This active mydriasis is because of stimulation of dilator pupillae. Whereas passive mydriasis is what your atropine-like drugs or your anticholinergics show, where the dilatation of the pupil is mainly because of relaxation of sphincter pupillae and M3 blockade. Then how do we differentiate active and passive mydriasis? When light reflex is absent, it is passive mydriasis, and when cycloplegia is present, it is passive mydriasis. You simply think, place yourself, a lion is falling behind, running behind you. Obviously, you'll be apprehended, you'll have tremors, you'll be restless. In the same way, to run away, you need lot of blood glucose, for which there will be glycogenolysis and gluconeogenesis and hyperglycemia. And steroid and your lipid breakdown gives you much more energy. Following this logic only, usually lipolysis is favored by adrenaline, resulting in hyperlactic acidemia and calorigenesis. At the level of respiratory system, beta 2 agonistic action causes prominent bronchodilation. In the same way, at the level of uterus, because of beta 2 mediated relaxation happens in the human. Effect on GIT, bladder, and splenic capsule, they are not that significant, but GIT relaxation happens. Bladder micturition will not be free. Splenic capsule, more RPC will be poured into the circulation. Then where is adrenaline used? Adrenaline per se is used in anaphylactic shock, bronchial asthma, cardiac resuscitation, prolonging the duration of action of local anesthetic. For this use, we usually use this dilution, 1 in 1 lakh dilution of adrenaline to control epistaxis or other hemorrhages where a dilution of 1 in 1000 to 1 in 20,000, whatever can be used, and then glaucoma. In the case of anaphylactic shock, where there will be prominent vasodilatation, cardiac depression, and bronchoconstriction, which are mainly mediated through IgE mediated histamine release. Adrenaline is a physiological antagonist of histamine. Adrenaline, by acting through alpha 1 receptors, causes vasoconstriction and increases blood pressure as well as reduces mucosal edema. In the same way, by acting on beta 1 receptors, they increase cardiac output as well as force of contraction and increases blood pressure. By mediating beta 2 action, bronchodilation is seen. By this, The triad of anaphylaxis is being reversed. For anaphylactic shock, adrenaline is used at a dilution of 1 in 1000 point 0.5 milligrams intramuscularly. Along with adrenaline, hydrocortisone is also used. For prolonging the duration of local anesthetic, let us say you are removing a lipoma or some dental extraction is happening. Do you want your local anesthetic to be diffused into systemic circulation? Obviously, no. For that reason, we usually add a vasoconstrictor like adrenaline to local anesthetic at a dilution ranging from 1 in 80,000 to 1 in 2 lakhs. Because of the vasoconstriction, absorption of local anesthetic into systemic circulation will not happen. In the same way, systemic toxicity of local anesthetic is being reduced. In the same way, local anesthetic agent will be present at the site needed for prolonged duration. So, prolonged anesthetic effect. And also, because of vasoconstriction, there will be bloodless field of surgery. In bronchial asthma, we have wonderful analogs, wonderful other sympathomimetics, but adrenaline rarely can be used in status asthmaticus. In cardiac resuscitation, during cardiopulmonary resuscitation, during cardiogenic shock, adrenaline is used. To control epistaxis or any other sort of local bleeding, we usually use a local pack of either 1 in 1000 or 1 in 20,000 dilution of adrenaline, and we put it at the site of bleed. Glaucoma is a condition where there is increased intraocular pressure. Glaucoma is usually reduced by adrenaline, mainly by either reducing the synthesis of aqueous humor or increasing the drainage of aqueous humor. Any of this can be responsible for glaucoma reduction. But adrenaline per se is not used, mainly because adrenaline, when used as an eye drop, cannot be absorbed into cornea. So, we use dipivefrin, which is a prodrug of adrenaline, which you happily crosses the lipid layers of eye and gets converted into adrenaline. Then, what are the adverse effects of adrenaline? Adrenaline, when given through intramuscular route or subcutaneous route, causes transient restlessness, palpitation, anxiety, tremor, and pallor. Whereas if given through IV, causes marked rise in BP resulting in hemorrhage, VTAC, angina, or MI. You can notice here adrenaline is not given orally, mainly because whatever adrenaline we take orally is usually metabolized either by MAO or COMT. What are the contraindications then? Usually, for any patient who is suffering from heart diseases, hypertension, hyperthyroidism, we must be very cautious while using adrenaline along with local anesthetic agent. I want you to have this glimpse table where adrenaline is used in anaphylactic shock in a dilution of 1 in 1000 and preferred route is intramuscular. For cardiogenic shock, the dilution is 1 in 10,000 and intravenous route is preferred. For epistaxis, the dilution is 1 in 10,000 where nasal pack is usually used. Along with local anesthetic, they're ranging from 1 in 80,000 to 1 in 2 lakh. We can use whatever dilution is available and is given subcutaneous or whatever route we are using for the local anesthetic agent. I want you to know the difference between noradrenaline and adrenaline. Both are catecholamines. A simple methyl group addition for adrenaline gives it agonistic action even at beta 2 receptor, because of which the effect on BP is biphasic, where there is increase in the systolic pressure as well as decrease in the diastolic pressure. This effect is not seen in monophasic, not seen with adrenaline, where there is continuous rise in blood pressure. Because of this continuous rise in blood pressure, there will be bradycardia associated, and because of these effects only, clinically rarely noradrenaline is used, and if at all it has to be used, it is used mainly to reverse hypotension. Thank you for listening. I hope the concepts of adrenaline is clear for you.